Well, a warm welcome to this talk. Now, like me, many of you have been following the UK COVID inquiry, and I've just been listening to Anna Norris, King's Counsellor, as she gives the opening statements, really, for the COVID vaccine adverse reactions bereaved groups. Now, this is, I think, three groups that are together here that she's representing. People with vaccine injuries, and she stresses these people are not anti-science, they're not anti-vax, they're real people with real injuries that need to be investigated and taken seriously. And she talks about the need for change, the need for compensation. She wants questions to be asked about vaccine production, regulation and rollout, and that the need to understand the data. But of course, that means the data needs to be released. Now, I'm optimistic that we're going to get data release in the United States. I don't think we're going to be getting data release from the United Kingdom government anytime soon. And I don't think we're going to be getting information released from the pharmaceutical companies unless the new administration in the States orders that to be released. And even then, it could take a bit of time. She points out that basically everyone in the UK was put on a phase 4 clinical trial. Now, given this was the case, given that the government wanted 75%, 85% of the population vaccinated, then it was completely, utterly inevitable that there was going to be adverse reactions. So why weren't systems put in place for this? Why wasn't the yellow card data distributed? Why didn't doctors and nurses, when someone arrived with a new complaint, say, well, have you been recently vaccinated? Because we do this for everything. When someone comes in, we say, do you smoke? Do you drink? What's your family history? Do you exercise? What's your diet like? Do you take any medications? Do you take any herbal medications? We ask all this. So why should it be that asking about a COVID vaccine, especially because it's a new intervention, was considered not really the thing to do? There was a lot of political imperative to develop the vaccine in the United Kingdom that she talks about. And she talks about thrombosis, thrombocytopenia, myocarditis, Guillain-Barré syndrome, hematological conditions and neurological conditions. Now, so far, I must say I'm pretty pessimistic with this inquiry. It all seems to be lawyers. And it's a bit like watching a court trial. And, you know, the way that lawyers have of sort of, I don't know. You watch it for yourself and see what you think. It just seems to be very legalistic. I would prefer something that's much more scientific, many more doctors and scientists and data scientists involved giving information rather than lawyers, which it seems predominantly to be lawyer-based. And I'm concerned that it's becoming adversarial. Let's hope the inquiry has not decided what the outcomes are going to be before the inquiry, that it is a free and open inquiry. Although at the moment I'm quite uncomfortable about a lot of things. Why was vaccine injury basically ignored by government and media? And many of us who've investigated these things have been attacked, quite openly so. Why were therapies overlooked is another obvious question. We've looked at therapies on this channel. So yeah, okay, you can hopefully prevent with a vaccine. We can argue about the degree to which it did that or didn't do that. But once someone becomes ill, we can take therapeutics, and we've looked at evidence for many therapeutics that could be highly effective. No, we're going down the vaccine route. And the therapeutics that were there were from big pharma and typically highly expensive, with the exception of steroids, which were so obviously efficacious that they had to be used. Why was there indemnity offered so early, so quickly? Was it that indemnity was offered because it was highly suspected or even known that these adverse reactions were going to occur? Why wasn't full data released? What about the manufacturing process? Why was it that the manufacturing process for the Pfizer vaccine that we looked at, for example, was different for the vaccine, most of the vaccine used in the trial, and the vaccine actually rolled out? How could that have been allowed? Serious questions to be answered there. Let's hope this inquiry really does answer these issues. Let's hope. We can hope they do. Why weren't the public educated on adverse reactions? Look, you've had this vaccine. Look out for this adverse reaction. Then they could go to the doctor and get it properly treated. But no, that wasn't done. You were told to sit in the waiting room for 15 minutes in case there was an anaphylactic reaction. But apart from that, we weren't really warned about anything. Really very strange. The risks should have been made known at a much earlier stage. Why was there not an index of suspicion about adverse reactions and death? Well, why wasn't this suspected more? She talks about so many things. You have to watch it. It only lasts for 18 minutes. Why weren't staff trained on yellow card data so that they could be aware of adverse reactions as soon as they occurred? Even doctors and coroners very often gave unsatisfactory verdicts. Many are still fighting for compensation, of course, but to be fully aware of the cause of death, unless you know what killed one of your loved ones, you can't really start the grieving process, which of course is essential. And if someone had an intervention that's safe and effective one day and died the day after or the week after, just to say there's no link is not a satisfactory explanation to that. Why was there a hostile reporting environment? If you reported that, why did people receive hostility? Very often from the healthcare providers that were supposed to be looking after them. Doctors that did raise concerns very often weren't listened to or were attacked in various ways. Again, as we've looked at on this channel many times. Why is there still ongoing stigma? Why is there still a lack of mainstream coverage of injuries and bereavement? And that's why social media, of course, came to the fore. People were stuck at home, suffering from these injuries, and they weren't being covered on the mainstream media, nothing like adequately. They weren't being recognised by the government. They weren't being recognised by doctors. So where are they going to go? They're going to look for people with a similar experience on social media. And yet in one of these groups, 74% of people that reported on social media, largely about their own symptoms, were censored. Where was this censorship coming from? Anna Morris herself was censored about data she was going to submit to the National Inquiry. Absolutely incredible levels of censorship that we've endured and are still enduring. I still can't talk about lots of things now. Why were injured people removed from social media for simply talking about their experience? Someone's experience is real by definition. It's what they experience. Pain is what the person says it is, existing when they say it does. She talks about the need for vaccine injury and compensation, for full compensation, of course. Public confidence at the moment is at rock bottom. That needs to be rectified. And in my view, we need something called like a Truth and Reconciliation Committee. But anyway, that's just a quick review of what Anna Norris says. Do watch the whole thing now. I'm going to play it, and well worth watching.
My lady, I, alongside Mr Weaver, Mr Mark Bradley and Mr Wilcox of Hudgell Solicitors, represent three groups who together are recognised by the inquiry as the COVID vaccine adverse bereaved and reaction groups. These three groups are the UK CV family, the Vaccine Injured and Bereaved UK, and the Scottish Vaccine Injury Group. You will hear powerful evidence from Kate Scott, Charlotte Crichton and Ruth O'Rafferty on behalf of these three groups during your inquiry. The thousands of people that these three groups present what is an uncomfortable truth for many, that vaccine injury and death are part of the pandemic story. These are men, women and children who are otherwise healthy, who followed public health advice and voluntarily attended to receive their vaccine. They include doctors, healthcare professionals, carers and parents who accepted the vaccine thinking not only of themselves but of their patients and those who they cared for. Those I represent are neither anti-science nor are they anti-vaccine. They are real people with real experiences. And my lady, this inquiry must recognise and acknowledge the real experiences of the vaccine injured and bereaved and their need for real treatment, real care and the need for real change in the way that vaccine injuries are reported and addressed. For too long, they've been ignored by the government, public health bodies and the media. The COVID vaccine adverse reaction and bereaved are not just an unfortunate statistic or collateral damage to the government's vaccination strategy. They are individuals and families calling upon the health service and the government for urgent help. So, my lady, what does the inquiry need to understand about COVID vaccine adverse reactions and bereavement in this module? First, the inquiry must understand the decisions that were made around the production, regulation and rollout of the COVID-19 vaccines. The groups I represent question what was the so-called acceptable risk of the COVID-19 vaccines to them. And were those risks communicated in an effective way, which meant that members of the public were able to provide informed consent to vaccination? There was clearly a political drive for the UK to be seen at the forefront of global vaccine development, and we asked the inquiry to interrogate whether political pressure created an environment in which the assessment and the regulation of the safety of vaccines was not as robust as it should have or could have been, or whether a focus on vaccination meant the alternatives, such as therapeutics, were overlooked. We understand, for example, that the inquiry will hear evidence that the UK government agreed to pay AstraZeneca in advance for the supply of a potential vaccine, and that the government also agreed to indemnify them and the other pharmaceutical companies, such as Moderna and Pfizer, in respect of any losses from certain third-party claims. The purpose and the impact of this indemnification needs to be fully understood. Was this standard practice? Or was this a recognition by the government and the pharmaceutical companies that there was a safety risk in the development and distribution at such speed, which required special indemnification? The COVID vaccine adverse reaction and bereaved groups also want to understand the data available to the companies from their clinical randomised trial data and how this information was presented to the UK regulators. Where vaccines were scaled up from those tested in clinical trials, were the regulators presented with accurate safety data for the products that were in fact rolled out to the public? We also ask, how did the MRHA and the JCVI scrutinise data, particularly with regards to those who commenced but did not complete the trials? Second, my lady, the inquiry must understand the post-rollout surveillance and monitoring of the vaccines. Although the desire for a vaccine at speed may have been understandable, the fast-track process for the development and rollout that followed meant that the stringent post-authorisation surveillance and monitoring was essential, as was public education and information on how to identify and report any adverse reactions to the vaccine. Essentially, the vaccine rollout put everyone in the UK in a Phase 4 post-authorisation trial. We were the real-world data that Mr Keith Casey referred to this morning. This made it imperative for the government and the NHS to ensure that there was an effective system in place that was well organised and signal sensitive to monitor, detect and treat any adverse effects. My lady, adverse reactions were to be entirely expected. As acknowledged by Mr Keith, King's Counsel, this morning, any statistical probability on a population level of serious side effects such as thrombosis, thrombocytopenia, myocarditis, Guillain-Barré syndrome and other serious haematological, neurological, immunological and musculoskeletal injuries does not undermine their severity when they occur to individuals. Therefore, it must have been clear when rolling out the vaccine to millions of people, if the planning assumption was that 75% of the population were to be vaccinated, that there were likely to be vaccine-related deaths and serious vaccine injuries, however rare on a population level, that would require urgent identification, treatment and care. Many of us were vaccinated by our GP or our local healthcare provider. The BMA estimates that in England this was by over 70% of those vaccinated. We ask, were GPs also provided with sufficient information and training in relation to how to spot and report vaccine injuries? Many of us were vaccinated in mass vaccination centres and received multiple doses across different settings and from different manufacturers. We ask, were those who were vaccinated and vaccinating always advised of the latest information surrounding known risks? Was the patient information leaflet always up to date and available to those being vaccinated? Where changes were made to a safety profile, the inquiry must question whether public health messaging was early enough or clear enough in order that individuals could properly assess the risks to them. Also, was there a full understanding of whether multiple doses would impact of any risk of injury or further compound any existing vaccine injury? As Professor Stephen Evans points out in his written report to the inquiry, it could be said that safety is always provisional, in the sense that with rare events it may take some time to be detected. The logic to this statement is that vaccine risk assessment and risk management must retain an open mind to the occurrence of adverse events. What Professor Evans calls the degree of an individual or a system's index of suspicion. Our groups question whether the UK government, regulators and the NHS had a sufficiently high index of suspicion to identify vaccine-related deaths and to treat vaccine injuries when they occurred. For example, Given that it was known that there would be adverse effects from the vaccine, some of which might not arise immediately, why were the public and healthcare professionals not alerted to the possibility of delayed onset adverse reactions or the potential for adverse reactions that are of an unknown nature? My lady, you've heard from those in the Impact film, and you'll hear from the witnesses from the groups tomorrow who detail the experiences of those whose vaccine injury symptoms were dismissed, ignored and misdiagnosed, sometimes resulting in catastrophic escalation of the injury or, in fact, death. It is likely that much of the inquiry's evidence from the government and public health bodies will highlight the yellow card scheme and the additional yellow card pathway introduced for the COVID-19 vaccines as the most effective way of identifying adverse effects or safety signals. But medical and emergency staff should have been given training and directives requiring them to identify any conditions arising after vaccination and to immediately report them. This would have been crucial both for ensuring appropriate treatment and for collecting data on emerging side effects. For example, why was there no guidance stipulating that medical professionals should ask patients who attended hospital or a medical appointment with new symptoms whether they've been recently vaccinated, similar to the way in which questions are routinely asked about smoking, other medication and drug use as part of a standard health examination? Those in our groups have experienced disbelief and sometimes hostility by medical professionals when reporting their symptoms. Doctors and coroners have refused to accept that injuries or deaths were caused by the vaccine. Suddenly losing a loved one following a, quote, safe and effective vaccination is a massive trauma. Then being told that the cause of death is not related at all to the vaccine adds indescribable distress. Members of our groups continue to fight for the true cause of death to be recognised, leaving them unable to find closure over the loss of their loved ones. But we say the problem goes further than a lack of training or a lack of suspicion. The inquiry must have the courage to examine how the public messaging, narrative and the context of the vaccine rollout created a hostile environment for the reporting of COVID vaccine-related deaths and injury. The inquiry will recall the mantra, follow the science, from Module 2. In Module 4, our groups question whether that mantra and that mindset contributed to a culture of political and public pressure which dictated that vaccines were inherently good and that there would be no adverse reactions expected. My lady, scepticism and challenge are all valuable parts of scientific analysis, but sadly those within our groups were likely to be branded by those designing public health messaging as being anti-science or even anti-vax. The vaccines were consistently reported as safe, with members of the public being told in messaging, you must have them. Everyone's personal freedoms, ability to travel, go to work or to visit loved ones often depended on being vaccinated. The government also provided healthcare providers with financial incentives to maximise vaccinations within their communities. This must have contributed, even unconsciously, to a mindset that the vaccine must be delivered at all costs. The inquiry should be quick to identify any development of vaccine bias within healthcare settings which could have impacted on healthcare providers' ability to properly identify symptoms of vaccine injury. Within our groups, there are also numerous doctors within the NHS who had their own concerns about the vaccine, but were instructed to keep those concerns from the public, including their own patients. We should all find this form of cultural censorship deeply troubling. Thirdly, my lady, the inquiry must understand the stigma and censorship attached to the vaccine injured and bereaved and how that is preventing them from accessing the treatment and the care that they need. One of the biggest issues that they have faced up until this point is being stigmatised, discriminated against and censored when they've used their voices to speak about their experiences of bereavement or life-changing injury. Husbands, wives, mothers, fathers, sons and daughters who have been killed or severely injured by the COVID-19 vaccine. Each death or injury has placed considerable emotional and practical strain on families, with some members having to become carers, leave their jobs, lose their homes, rely on food banks and face many other devastating consequences. During the early months of the vaccine rollout, those who experienced adverse reactions found it nearly impossible to access information about the vaccine injuries in the mainstream media. When they were eventually covered, the stories were often framed with an emphasis on the rarity of such reactions, the safety of the vaccine, and the millions of lives it has saved. Having been disbelieved by healthcare professionals and ignored by the mainstream media, those injured or bereaved by the vaccine turned to each other for recognition and support. They use social media to connect with each other, share stories and express their grief. A poll of all UKCV family members revealed that 74% have been censored when talking or posting about their adverse reaction to the vaccines on social media. One member of a group posted his experience on developing blood clots and other debilitating symptoms following his vaccination. His post was removed and described as false and harmful. Unfortunately, this censorship has continued years after the pandemic and into our engagement with this inquiry. YouTube removed a video featuring my legal submissions to you, my lady, on the 13th of September 2023. And despite requests for a thorough review, YouTube cited a violation of its, quote, medical misinformation policy as grounds for removal. Given the speed and novelty of the vaccine rollout in the pandemic, the UK should have created an environment in which safety signals around adverse effects could be spontaneously reported and data collected. It should have been recognised that when the yellow card system was not able to capture all the signals, that social media was a rich source of information and support for those concerned that they were injured. Instead, the strategy seems to have been deployed in relation to posts about vaccine bereavement or injury, which is simply to remove them from social media, to silence their voices. There does not appear to have been any effective attempt by the government or public health officials to use social media or even traditional media to meaningfully increase awareness of vaccine injury reporting schemes or to offer support and access to compensation for those who had suffered. Could a reason for the rise in trust of social media have been that people were able to find information about the adverse effects they'd experienced from the vaccine at times when government and official sources were silent on these matters? The psychological and emotional impact of those suffering from adverse effects of the vaccine, coupled with the silencing and discrimination against them, is likely to contribute to future vaccine hesitancy if not adequately addressed by this inquiry. Fourth and finally, my lady, the inquiry must urgently address the inadequacies of the vaccine damage payment scheme. The government knew at the time of the vaccine rollout that very rare adverse effects of COVID-19 vaccine will only be observable when there has been a large-scale rollout. Therefore, it was clear, we say, that there would have been a need for an efficient system to address vaccine injury that could satisfy the moral duty of the government to act in a way that was just towards individuals who suffered a disability or death as a result of engaging in a government-run health protection scheme. The COVID vaccine adverse reaction and bereaved groups are clear that the VDPS is not fit for purpose. Their calls for urgent reform have been supported by parliamentarians in both houses and legal academics. They have highlighted the moral and social duty, underscoring the VDPS, and underlined the fact that if there is no reform, there are likely to be significant implications for vaccine confidence, something that Mr. Keith, King's Counsel, recognised himself in his observations to you this morning, my lady. The DHC itself acknowledged in its impact assessment for the expansion of the VDPS to include the COVID-19 vaccines that, quote, all citizens gain from the knowledge that the government would award financial assistance if they were severely affected. My lady, you will hear tomorrow some harrowing stories from those who've had to wait inordinate amounts of time to have their claims resolved, often only on appeal, causing significant and compounding further distress for them and for their loved ones when they need support the most. No one who has watched this morning's impact film can be left in any doubt of the level of distress that the VDPS rejection can cause to those who are vaccine injured or bereaved. Many individuals experienced severe injuries that required urgent and protracted medical treatment, sometimes taking months. It was only after this point that doctors would acknowledge or confirm that the injury was caused by the COVID-19 vaccine. Many of these individuals were only able to make an application to the scheme when they were well enough to do so. They then faced 18 months to 2 years of delays in processing their claim and receiving payment. Mr. Keith has touched upon the disablement criteria, but the notion of a 60% disablement criteria is not one generally recognised in UK personal injury law and is attributed to a pre-war pension scheme and industrial injuries. We agree with the evidence before the inquiry in writing from Duncan Fairgrieve KC that the current system is unfair, and we say it needs urgent reform. It must now be clear that reform is urgently required and the current system has not met the needs of the injured and bereaved. There have been promises made by the previous and current government to look at the VDPS, but here we are 4 years after the first vaccination and there has still been no action taken. My lady, your inquiry, like the many others before it, will be judged on the implementation of its recommendations. The imperative for you, therefore, my lady, we say, is to assist the effective implementation, is to thoroughly investigate the evidence with a view to making urgent, clear and meaningful recommendations, we say via an interim report, combined with a robust monitoring framework to deliver the long-awaited support to those who have suffered and those who continue to suffer the adverse effects of the vaccine. This will not wait until 2026 or 2027. Action is needed now. Importantly, as Mr. Keith acknowledged this morning, effective support and care for the vaccine injured and bereaved is inextricably linked to vaccine hesitancy. If the status quo is allowed to continue, public confidence in future vaccination programmes will be affected, as those that are asked to engage in vaccination can no longer have the confidence that there is any effective safety net for their physical, mental health or financial needs should they need it. In conclusion, my lady, of course the groups I represent are grateful for being granted participant status in this inquiry, but our simple presence at this inquiry is not enough. What we trust the inquiry will hear loud and clear from these submissions and those we have made on previous occasions is that the voices of the COVID vaccine adverse reaction and bereaved will not be dismissed or ignored. Their experience with Every Story Matters and the report that's been produced has not given the vaccine injured and bereaved groups confidence that the inquiry has yet fully understood their lived experience. But we hope that Mr. Keith's words this morning reflect the inquiry's ability to listen during these evidence hearings. The inquiry must now listen to their voices and reject the stigma that has so far been attached to their stories in order that the truth can be acknowledged. Only then can the inquiry propose meaningful change to benefit future pandemics. We raise significant questions and make substantive proposals, which we ask this inquiry to break with the failures of the past and demonstrate what can be achieved by way of recommendations when the bereaved and injured are listened to. My lady, those are the opening submissions on behalf of the COVID vaccine adverse reaction and bereaved groups.